Friend, Dr. Nakulsina. The title of his presentation is Dedicated Bifurcation Stents.
A very good morning. So the topic is dedicated bifurcation stents. Now, as with everything, we expect a lot from interventional hardware. So the ideal device, if ever there is one, will possibly be a drug-eluting stent, which is easy and simple to use, but is still giving us very good results, which have to be predictable and which practically should be able to cover most, if not all, types of bifurcations, with a low rate of restenosis and a negligible stent thrombosis. And I think you will realize by now that we are asking for too much. The mere fact that there have been so many, more than a dozen or 24 attempts or even manufacturers of dedicated bifurcation stents tells us that we are still very far from achieving perfection. How can we take a simplistic look on that? They can be either self-expanding or balloon expandable, and focusing either on the main branch or on the side branch, which is to be tackled first. Now, all this will depend upon the anatomy, whether the side branch is more important, sometimes bigger, what is the angle, etc., etc. So this self-expanding, focusing on the main branch, I think the prime example is the Stents, which has been there for quite some time. Focusing on the side branch is this capillary stent, and focusing on the side branch balloon expandable is this Triton, where we have had 1 or 2 trials around 3 or 4 years back, and they have given us some reasonably good results. The other easy way to understand the structure and model of these dedicated bifurcation stents is to see whether they are providing access to the side branch while being in the main branch, or they are first being put in the side branch and then the main branch is being tackled, or there is a proximal bifurcation stent. I think the prime example is Access from biosensors. And then there are truly dedicated, prefabricated bifurcation stents with 2 arms already there. So let's try and take them up one by one and see how things go. So if we take the side branch access device, the stent is, as I said, it is put in the main branch. It's a nitinol and either a bare metal or a paclitaxel stent version, and it provides a good access to the side branch. Now, how does it do that? That once you deploy it in the main branch, there are disconnectors along the stent. There are disconnectors along the stent, and they open up and provide you access to the side branch. So this is the detail of the disconnection technology, where first you put it in the main branch, then you wire the side branch and inflate at low pressures, and then you can have the cells which open up and provide you passage to place another stent in the side branch. This was the Open-2 study. Well, it was a reasonable result, although a 10% MACE. But if you take the previous results of all the bifurcation trials, starting from BBC, Nordic, Cactus, etc., then the results of this open study were not bad at all. So the total MACE in the total group was around 10%, but in the simple lesions it was around 7%. This is another stent design where it is sort of tailored for the asymmetric and the curvy stent or ostial geometry, where the vessels are not that straight. And there you can choose accordingly and try to have locators placed at the bifurcation point so that you can have easy access. There are others also in the field, like this Zeiss SPA stent, the Nile packs, etc. So all these are probably clones of the same design with minor differences which can perhaps help you in choosing them for a particular case. If we come to the second type, that is the stents which are placed in the side branch first. So the Triton and side guard are the main examples. The Triton has more clinical experience. And there you place this balloon expandable stent in the side branch and then tackle the main branch. Now obviously they will be used for patients who have more disease towards the side branch. And these are the diameters and the relative diameters which you find, and it's usually a bare metal stent, and these are the zones, the side branch, then the zone of transition, and then the main branch, which is minimal metal there, and then you can tackle the main branch. So the deployment sequence is that first you deploy after pre-dilatation of the side branch, then the main vessel is treated with a DES, and then you end up with a final kissing balloon. This was the Triton study design, a nice, elegant designed study. It included around 700 patients, divided them, randomized them with 9 months follow-up, angiographic, and a subset of IVUS follow-up. Now, the target vessel failure was slightly higher with Triton, but not significant, not statistically significant. But the point, or rather the objective of non-inferiority just fell short. So, I mean, that is still in the development and experience stage. But the lessons it gave that this is a feasible technology, and at least the side branches developed the minimal level of complications by using this type of Triton stent. This is another capilla side guard, because all this is placed in the side branch, and you can have a flared up entry from the main to the side branch. So that minimizes any trauma to the ostium of the side branch. This is a depiction of how the stent is placed in the side branch, and you can have a go at the main branch easily. The clinical outcomes were not that bad, but then again, it will need a lot of more trials and registries. Now, this axis stent is quite unique and popular for many reasons. Firstly, because it can tackle large branches, with both side branch also being a big one. And it is a proximal bifurcation stent, because it flares up and gives you access to both the side branch and the main branch. And you can place it nicely with 3 markers which are there. In fact, I have used a couple of them. And there is even a left main system which comes in bigger diameters, where you can use it in left main true bifurcation lesions. So that's sometimes very helpful. This is another bigger modifications and sizes which are now available. Initially, it used to be very few sizes. At least the initial registry showed a slightly higher MACE rate at 4 years. Well, it wasn't very high, but yes, significant enough. And then 1 or 2% of a stent thrombosis. But it needs more dedicated handling, more experience, and then possibly it may give us a better result. Coming to the true bifurcated stents, which have been designed to, right from the word go, to have 2 arms of metal with probably 2 wires and balloon in different passages. So this is a Medtronic dedicated bifurcation stent. It's still not available freely, but there are trials going on in different parts of the world, and you can see that the deployment needs simultaneous tackling of the side and the main branch. This is another bifurcation optimized stent system. The difference here is that there is a marker which is placed at the ostium of the side branch, and there it opens up easily. The design of the stent is such that that middle portion is made to open up the cells and provide you good access. So there are these test platforms, there are registries, but see, okay, there have been lots of innovations, But the mere fact that we have so many of them in the field tells us that we are still far from perfection. And concerns and questions about technique, the appropriateness, the lesion type, the lesion length, etc., will always remain. And there is still a long way to go before we reach a consensus as to whether, first of all, these dedicated bifurcation stents have a practical advantage in treating true bifurcation lesions in real life situations, not in trial ones. And certainly, if we reach there sometime, then the left main bifurcation, if it can be tackled with one stent of a particular design, that would really be great for us. So, I mean, in the end, let me say there is no one technique for all bifurcations, and therefore there cannot be any one dedicated bifurcation stent for each and every type of lesion. And we need a lot of training, exchange of ideas, and then possibly we'll see some light at the end of the tunnel. Thank you very much.
Thank you, Nakul, for your excellent deliberation. Siras, can we call the next person?
Yeah.
Now I invite Dr. Carsten Sope for his deliberation on practical approach in heart failure management, role of RNA. Carsten, please.
I'd just like to introduce him more briefly. He's an interventional cardiologist, got interested in heart failure program, and is one of the best universities in Europe which is dealing with this. I request him to come over and deliver his talk on the heart failure.
So, where's my talk? You know how I can find my slides? Yeah, the company has done it. Novartis. I have not done it. The company has done it. I don't know. I have my own stick. Is this the stick? Now you're too late, I fear, my friend. But it costs a lot of... Put it on. Yeah, hello everybody. Sorry for let you waiting. I just arrived from Germany. Difficult enough. I took a shower and now I prepare the slides. And as you have heard, I'm an interventional cardiologist, and it's very important also to know a lot of things about heart failure. On one hand, we are doing a very good job with our stents and our techniques, so preventing dying from myocardial infarction. However, indirectly, thereby we are producing survivors with reduced ejection fraction, so we interventional cardiologists are also guilty by producing patients with heart failure. And therefore, it's so extremely important to know what's going on here. You see here worldwide more than 26 million patients have heart failure. The prevalence is high, is rising, and the reasons behind the good job of interventional cardiologists is, of course, aging and an increase of risk factors, especially also true for your country, thinking about diabetes mellitus. Fighting against heart failure means that we do not have stents itself. We have specific medications, and they are summarized here on this slide, and especially those who interfere with the neurohumoral activation, like ACE inhibitors, together with beta blockers and aldosterone antagonists, are those drugs which help us. And you can see, although that we have these drugs, mortality is still high. You see that here about 50% of the patients are not anymore with us after the first diagnosis of heart failure. So that means we still have to do something. And in the last years, it came up in new strategies. This is here just a slide from the European Society of Cardiology, how to fight against heart failure. When we see that patients still suffer despite ACE inhibitor, aldosterone antagonists, and beta blockers, we get 3 new tasks. One of them is to prove what's going on with the heart rate. Is the speed higher than 70 beats per minute despite beta blockade? We have to add ivabradine. This is at least the belief in Europe. And the target heart rate is about 60 minutes per minute in patient with reduced ejection fraction. The another task we got is think about the QRS duration. This is larger than 150 milliseconds. Then we have to give a CRT system. And now it comes something what is extremely surprising as it came up before, is that the guidelines recommend to take the ACE inhibitor away in a patient where you have signs of the progression of the disease. And that is really something what sounds as a paradigm shift, because usually I would have told you when the patient's disease is progressing and progressing, add probably more ACE inhibitor. But here the guidelines say take the ACE inhibitor away and give therefore another drug which we call ARNI. And the reason for this is, according to the paradigm trial, where the first ARNI, sucralfate valsartan, had been investigated in about 8,000 patients with reduced ejection fraction. They had been treated optimal on the base of an ACE inhibitor or on sucralfate valsartan. We got an additional risk of about 20%. However, calculating relative risk, I think this is not really something what you can grab. A patient who knows that he has a disease which kills him with a 50% chance in the next 5 years, you want to know how many years I could live longer, and this is summarized on the next slide, and you can see here, let's have a shift here to the left side, that a 55 years old patient has a chance after a simple shift from an ACE inhibitor like enalapril to an ARNI, that he can live about 2 years longer. And also with respect to the clinical progression, not only the question, can you live longer, but also the question how often the patient has to be retreated in the hospital is significantly reduced. So these are the data which have changed worldwide all heart failure guidelines. And this is here just an example from the American guidelines, and they have two different clinical scenarios characterized. The first one is that they say if you have a naive heart failure patient in front of you, it is allowed to start with an ACE inhibitor, with an AT1 receptor antagonist, an ARB, or an ARNI immediately. Or they describe the other scenario. The patient had been already pre-treated, for instance, with an ACE inhibitor, but we have signs of the progression of the disease. Then they recommend both clinical scenarios, recommended as a class 1 scenario, as a replacement scenario. So these are the clinical data and the guidelines. And the problem of a study or guidelines is that very often our problems in the clinic are not really covered. Very often our patients have more problems in addition, they are older, they have more comorbidities and never had been investigated. So the question is how to deal with these patients with respect to real life scenarios. And as this drug came in my hand and my clinic, I wanted to have it, of course, also for my patients, and I introduced my young doctors just with 3-4 different informations. First of all, I told them that it is possible that when the history of angioedema due to an ACE inhibitor is positive, the patient is not eligible for an ARNI. And that has the consequence that when the patient has been pre-treated with an ACE inhibitor, you need a 36 hours washing out period, and then you can titrate. If the patient has been already pre-treated with an ARB, you can switch immediately. And the other thing I told them is, it is possible that you affect blood pressure. And therefore, sometimes, especially when the blood pressure is lower than 100 millimeter of mercury, first you have to prepare the patient for an ARNI. So that is all what I told them, and so it means it is relatively easy for us to use the drug as heart failure specialist. But still, I have now 4 cases prepared, which I would like to discuss with you and to show what kind of thinkings and probably troubleshootings are necessary to help our patients. So this is a 55-year-old lady with an ischemic cardiomyopathy. Ejection fraction is fine. NYHA class 2. So she was not a patient just left the intensive care unit. She was a patient in my out-clinic situation, and she felt fine. She had no signs of congestion, and she was on a very good treatment, I think. High-dose ramipril as an ACE inhibitor, high-dose metoprolol as a beta blocker, long-acting loop diuretics. And I asked her, how do you feel? She said, fine, I'm not complaining. I asked her, how many steps are you walking? Oh, doctor, I'm not really walking steps. I have an elevator. So you see, the lady found already some tips and tricks how she could survive with her disease. And the question here is this a patient where we should think about to switch from an ACE inhibitor to an ARNI? Officially, she looks stable. She's not complaining, she is on a good treatment. However, she's good treated, and she's also very good treated with a diuretic drug. Diuretics are cosmetics. With diuretics, I'm able to stabilize patients very easy. So I think I need objective parameters, whether not only the patient, but whether also the heart is happy. You can do that with different things. You can do 6-minute walking test. I have investigated natriuretic peptide levels. So NT-proBNP was very high. So the progression of the disease was identified. And that means that she is not proper treated with that what's going on here, with ramipril only together with the other important drugs. And this is also that why we have to say that had been investigated in the paradigm trial. Very often the doctors believe in the paradigm trial, very sick patients, no option patient had been treated. No, look at that, 70% of the patients were NYHA class 2. Nobody thought about to change and probably a winning horse in a NYHA class 2 patient. But that was the winner of these patients and in the trial, and therefore I had decided to switch the patient to an ARNI under these conditions. Relatively easy. I just have taken away ramipril under these conditions, and what we can see under these conditions is that the BNP levels just were wonderful, reduced nearly up to a half, and also the patient itself, yes, she was NYHA class 2, but she told me, yes, doctor, I can realize that something happened, and that is also what we know from the patients when we speak with them. So, summarizing this case, when we speak about change from an ACE inhibitor to an ARNI, then we do not think every time about a NYHA class 3-4 patient and no option patient, clearly before decompensating. We think about NYHA class 2 patient mainly, especially in those where we have additional signs for the progression of the disease. So let's come to this case. I think this is an easy case. NYHA class 3, patient is complaining. He has a good treatment, and with high dose of ramipril, high dose thiazides, metoprolol, and spironolactone. And I think it's clear we want to switch here because the patient itself shows you already clinically that something does not go in the right direction. That we have done, we just have taken ramipril high dose away, gave Entresto high dose twice 200 milligram, and suddenly we had this problem. Systolic blood pressure was 90. What to do? Panic? No, I think there's no reason for panic. I think we have principally 3 strategies. First of all, go to the patient and ask, how do you feel? It's an asymptomatic hypertension. We should accept that. Sometimes doctors are coming and say, yeah, that is clear because valsartan, sucralfate had been used twice 200 milligrams, so the dose is too high. So just don't titrate. I do not believe this is the best because I strongly believe that in the trial, the winner was the neprilysin inhibition. And only when you have used twice 200 milligram, then you have a great chance that the neprilysin enzyme activity is inhibited up to 95%. So I would like to keep this dose, but I would like to see whether probably the other drugs, the co-medications, when I reduce these, I can produce some place for an ARNI the drug, why a patient can live up to 2 years longer. So, coming back to the mode of action, how an ARNI is working. ARNI is inhibiting these enzyme neprilysin, which is controlling the degradation of natriuretic peptides. And natriuretic peptides have a natriuretic diuretic effect. So when you block neprilysin, you induce thereby also diuresis. And therefore, it is meaningful, and that happened also in the paradigm trial, summarized in this slide, that doctors, when hypotension occurred, thought about to reduce diuretic co-medication. I never would go so far to say take it completely away, but I would say adapt the dose, produce some place for an ARNI, because this is the life-prolonging drug under these conditions. And therefore, we have done the following. I have just reduced thiazides, and I have used a long-acting, low-dose diuretic. I also have reduced spironolactone, and as you have seen, the patient had also some drugs on board which are not really necessary, some nitrates, called in my country Isokit, and I just have taken it away and just gave him some spray if he needed it. So under these conditions, I think I could keep high-dose valsartan sucralfate. Blood pressure went up, and I think this is the better treatment, and the patient was also more happy with respect to the NYHA status. So the key message here is, in the clinical routine, it can be possible to deal with the co-medication, in these cases with the diuretics, to produce place for a high-dose drug, which is really life-prolonging. What about this patient? The patient has an ejection fraction of 25, NYHA class 2 to 3. The patient is really sick, systolic blood pressure lower than 100. And my colleagues were only able to give low-dose candesartan as an ARB, 4 milligram. I think that means nothing. It is more or less a pediatric or psychiatric dose, together with a little bit beta blocker and a little bit spironolactone. I think this patient is really sick. I have not measured here natriuretic peptides, but I'm pretty sure we have to do something that the patient is here improving. So from my feeling, I would like to see sucralfate valsartan in this patient, but on the other hand, we have this blood pressure issue. What to do? I think we should switch, because we have data showing that even low dose of an ARNI is better than a low dose of an ACE inhibitor, as you can see here. And even the mid doses of an ACE inhibitor was not as good as a mid dose of an ARNI. So I was pretty sure that I was never able to give these patients I have described before twice 200 milligram. But these data here indicate that even twice 50 milligram are better than 4 milligram of candesartan. So if I summarize this here together, I would say, when we have an ARNI on board, we have to control in the next 7 to 10 days blood pressure, potassium, and kidney function. If this is fine, everybody is happy. If you have hypotension, and it is not a symptomatic hypotension, everything is fine. It is an symptomatic hypotension, then prove the co-medications. And only when, even after proving the patient still have symptoms, then reduce the dose and adapt so that the patient feels happy. So that is what we have done under this condition. It was clear for me that sucralfate valsartan, as I said, 696 was a prolonged name before, I could use only twice 50 milligram, and I have done a good thing for the patient. E to E prime followed, blood pressure stayed stable, and I'm pretty sure that the patient has now the best treatment ever as possible. So that I would say here is my credo, even a low dose of sucralfate valsartan is a treatment target what we should offer our patient. My last scenario is renal failure. Renal failure and heart failure, of course, belongs together, and this patient here is suffering from heart failure, NYHA class 3, has a GFR of about 30. He had been pre-treated, in this case with an ACE inhibitor, lisinopril, and very often the doctors are asking me, what does that mean if I switch? Is this good or is this bad for the kidney? And here we have fantastic data. We can see here on this cartoon that also the progression of kidney failure is slower due to the drug. There are a lot of mode of action which can explain that. One of them is that we say when heart function is improved, also kidney function is improved. And for me in the clinic, it's extremely important to see that the potassium values stayed more stable under these conditions. And this has consequences for the co-treatment with the mineralocorticoid receptor antagonist. And you can see that here, if you combined mineralocorticoid receptor antagonist with an ACE inhibitor, the risk of very high potassium is very, very high, so that you in the end produce a non-responder for mineralocorticoid receptor antagonist if you compare that with succinylcysteine valsartan under these conditions. So for me it means, especially when you have a patient with reduced kidney function, as a consequence of heart failure, this could be an indicator that the patient will have a further benefit of the new drug. I never would go so far to say do it in patients with dialysis, and probably in patients where GFR is really low, you should do it in caution, but principally I would go for the new drug. So I come to the end and I would like to summarize. You have different clinical scenario. This is more or less the first American way where in all classes of heart failure, when ejection fraction is reduced, even in New Heart Class 2, you can start with an ACE inhibitor, an ARB, or an ARNI. When the patient had been already pre-treated, very often the clinical situation is difficult to decide when is the best way to switch, especially when the patient is New Heart Class 2, the patient looks relatively able and stable. Then I think we have to search in the clinic for so-called red flags. This can be clinical markers, serum biomarkers, hemodynamic changes. So when GFR, kidney dysfunction occurs, BNP is rising, or the patient has been already re-hospitalized, so it's a real clear sign that the ACE inhibitor is not anymore good enough, I think we have to switch under these conditions, so the patient needs the advanced therapy, probably in addition with ivabradine, within CRT, but in most cases the patient needs an ARNI that he has the best outcome chances. So I summarize, heart failure prevalence is increasing through the world. We have a triple therapy which is good, but for the most not good enough. Hypotension is manageable. This is not a contraindication. It belongs to the disease, and we as heart failure specialists are able to do so even in New Heart Class 2 patient, because mild symptoms does not mean mild disease. Thank you very much for your attention.
Thank you for excellent presentation on the role of ARNI in the practical approach of the heart failure. Can I call in a second guest lecture for a second guest lecture? Dr. Adnan Kastani. The end of the road for AVS and resurgence for the new generation DES. Dr. Adnan.
Thank you very much, Mr. Chairman, ladies and gentlemen. So if you look at these pictures here, which is not very, very rare in interventional cardiology, you see a lot of stents, which is called a full metallic jacket. You see several stent fractures, which is a factor that is associated with a higher risk of stenosis and thrombosis. And so on the other side, you see pictures like this, in which the stent is fully resorbed, and you see a beautiful lumen in OCT and IVUS. It's sure the idea of BVS, it's a great idea. At the beginning, this great idea was also supported by very good evidence. Here you see data showing that both vasodilatory and vasoconstriction function of the vessel is well restored after 24 months after implantation of the BVS. You have also very good data at 1 year regarding the reduction of angina. It was 30% with conventional metallic drug-eluting stents, and it was reduced to 21.8% with BVS. So, and at this time, it was well justified to write that bioresorbable scaffolds are considered as the fourth revolution in coronary stenting. The later evidence didn't support this assumption, didn't support this good results, initial results with BVS. So you have here the data from from the Absorb-2 trial at 3 years. And you see here, it's a very complex picture here, but you have to concentrate on the curves on the left. You see no difference between the science and the BVS regarding the vasomotoric function of the vessel. You see no difference, or at least it's a difference in favor of science stent. The late lumen loss was higher with BVS as compared with science stent. Also, the pretension that BVS is reducing angina was not confirmed by the Absorb-2 at 3 years. And you see here a lot of data, but angina-free proportion of patients, angina frequency, angina stability, physical activity, quality of life, everything of this parameter was not impacted at a positive way by BVS. So, and I'm showing here 3 editorials from us, showing also the dynamics of feelings about the BVS. So here, at the beginning, we wrote an immature technology in need for major application. That's why, at the moment, we were convinced that the technology was good, but the application should have been improved. The second editorial was entitled Bioresorbable Vascular Scaffold Technology Benefits from a Healthy Skepticism. As the evidence against the BVS was increasing, we wrote something like this. After the publication of Absorb-2 trial, the results were very negative regarding the BVS, we wrote Disappearing Scaffolds, Dissolving Expectations. At the end, we pulled together all the data coming from the randomized trials with Absorb versus Science, and you see here 7 trials with more than 5,500 patients pulled all together, and the results were very clear in disfavor of the BVS technology. The upper curves show the target lesion failure curves, which were higher for BVS, and you see that the odds ratios are moving from 1.23, that means it's a negative result regarding BVS, to 1.32, which is highly significant. That means that the risk of target lesion failure is increased by 32% at 2 years with BVS as compared with science. More importantly are the results regarding stent thrombosis or scaffold thrombosis. Here at 12 months you have a negative result in favor of science with an odds ratio increased to 2.52 with Absorb stent, and this odds ratio is increased further to 3.15. It means that there is an increase in the risk of stent thrombosis by 315% at 2 years. Not only stent thrombosis, but also a clinical event, myocardial infarction, is highly increased with the use of BVS. You see here that the odds ratio is showing 1.74, a 74% increase in the risk of myocardial infarction at 2 years with the use of BVS as compared with science. So this is a very representative case with the Absorb stent. We put the Absorb stent in May 2013. 2014, it was our policy to have control angiography in all these patients with receiving Absorb. You see, before the bifurcation of the right coronary artery, it's a perfect result at 1 year after implantation. The patient came back at June 2014, it means 1 month after having discontinued prasugrel therapy, and you see here acute myocardial infarction. The RCA is fully thrombosed, is fully occluded at the same site in which it appeared excellent 1 month before. This is not the only case. We have Meanwhile, we have 9 cases, and I am showing here 6 cases with the same pattern. An excellent control angiography at 6 to 8 months after putting Absorb, and coming later on with the scaffold thrombosis at the same site, which appeared perfect at 6 to 8 months. Now, is there any hope for Absorb technology? So you know that it was recommended to have this PCP philosophy, prepare the vessel, size the vessel appropriately, and post-dilate the scaffold. Last year, we had the results from the AIDA trial. The authors there have done a subgroup analysis looking at those patients in whom they adopted this PCB strategy and comparing stent thrombosis with those in whom they didn't use this strategy. It is a retrospective analysis, it is not a prospective study, but you see no difference at all. The stent thrombosis rate was higher in both groups, in those who had this PCP and in those who didn't have this PCP strategy. Meanwhile, we know also several mechanisms of scaffold thrombosis in these patients, but you have to concentrate here in the most frequent mechanism, which is scaffold discontinuity, which is seen in about half of those patients having scaffold thrombosis. There are other mechanisms like malposition, neoatherosclerosis, or underexpansion, but the discontinuity of the scaffold is the most important mechanism. I would say that hope is the last to die, and that the improvement of scaffold performance will be achieved by reduced strut thickness, improved scaffold deliverability, and shortening duration of its resorption, rather than by special training of interventional cardiologists. So I am for keeping this PCP philosophy, but it should be interpreted in another way. Progress in scaffold and platform polymer technology. But one question may emerge. After all these stories, which company is ready to invest billions of dollars to beat excellent current drug-eluting stent technology through trials with several thousands of patients? And many are thinking that the reason for this is that we have now very good drug-eluting stents based on metal. So I see also another problem that has to be considered in the future. We had very good results published in Lancet 2008 with Absorb stent. We had very bad results published in Lancet 2016 with the Absorb 2 trial showing a very high stent thrombosis or scaffold thrombosis rate. So it passed 8 years between the first excellent results and this final negative result, which induced also retracting the device from the market. Now, you may say preclinical studies may help. So far, they didn't help. Here, we have the results of a preclinical animal studies with Absorb, and the investigators there, they concluded Absorb demonstrates comparable long-term safety with science. They observe also expansillary remodeling, that means dilatation of the vessel after putting Absorb after 36 months. Resorption was considered complete at 36 months. Although this was not proved to be real in human studies. And it is a surprise to see that even in this paper, you see this picture here published but not interpreted as a negative picture. You see here discontinuing scaffolds, which is the most frequent mechanism of scaffold thrombosis, but the picture was left uninterpreted and without any implications. Now, it might be a new chance for BVS coming from extended follow-up of the Absorb studies. You have here the pooled analysis of the Absorb trials showing the higher target lesion failure with Absorb, the higher myocardial infarction rate with Absorb. If we will update the follow-up and see such a picture here, we will be very happy. That means after a full scaffold resorption, it might be expected that the incidence of myocardial infarction or target vessel failure will be higher with science as with absorb. But this is a hypothesis that should be proven with the extended follow-up of the absorb trials. For the moment, I would say that metallic drug-eluting stents will be the devices of choice even in the years ahead. And metallic drug-eluting stents are in two forms, permanent and bioresorbable metallic scaffolds. For the permanent metallic stents, I would focus on two kinds of drug-eluting stents that might be very important for cardiology community, especially in India. The Yukon Choice PC with biodegradable polymer drug-eluting stents and the Yukon ISAR PC non-polymeric drug-eluting stents. The unique features of Yukon Choice PC are that it is based on microstructured stent surface accommodation, reduction of amount of biodegradable polymer, and you see here two pictures. One of the stent without the coating, and on the right side of the picture you see the coated the coated stent. This structure, microstructured stent surface with biodegradable polymer, it achieves a very slow kinetics, release kinetics of the sirolimus drug. Another feature of this stent is that it allows for a high concentration of the drug, of the sirolimus in the vessel wall. You see very good results also in animal studies showing a very low inflammation score with this stent, which is comparable to the bare metal stent. You have also very good evidence at long term comparing this stent with the standard drug-eluting stents such as the Science stent at 5 years. No difference at all in the MACE rate, and the stent thrombosis rate is very low. Even it is lowest with the ISAR Choice PC stent as compared to the Cypher and the Science stent. Another kind of stent is the Yukon ISAR PC stent, which is the only non-polymeric dual drug-eluting stents. It uses the same microstructured surface of the stent, and on the other side it uses Propofol. Why we use Propofol in this device? Because Propofol is the only drug showing efficacy against restenosis after PCI, after PTCA. This is a New England paper of '97. On the other hand, Propofol also is able to slow down the release kinetics of sirolimus because it is very highly lipophilic. And you see here the effect on the release kinetics. It is very similar, both of Propofol and sirolimus, very similar to what is achieved by the combination of sirolimus with the biodegradable polymer. And you see also that the concentration in the wall, in the vessel wall, is very high, much higher than with the stent without Propofol. The animal data are also excellent, very low inflammation score, very low fibrin accumulation, which is much better than with the polymers. The comparison at 5 years with current standard drug-eluting stents with permanent polymer is also excellent, no difference at all. And this device shows a very, very low stent thrombosis rate at 5 years, 1.3%, which is very good, comparable with what we see in the practice with the current standard permanent polymer drug-eluting stents. 2 words about magnesium scaffold programs. The company that led this process was the Biotronic company in Europe. They had 2 devices, TRIMS-1, which was based on paclitaxel, and TRIMS-2, which was based on sirolimus. With the BioSolve-1 trial, we had not very good results because the late lumen loss with paclitaxel-based magnesium stent was high, 0.64 millimeter. BioSolve-2 trial, which used the DREAMS-2 device based on sirolimus showed better results in terms of late lumen loss. But you have to consider this is a very small trial, 123 patients, no comparison with other standard current drug-eluting stents. Thank you very much for your attention.
Thank you, Dr. Castrati. Since we have no questions at the end of a guest lecture, we'll bring this session to a close. Thank you very much. Thank you, one and all.
Thank you all, Chairperson.